Georgia McGowan, I'm the lead nurse for intensive care and high dependency unit, and I just want to give you a brief glimpse into the work that we do in our department. Intensive care is a very busy area. We provide very specialist medical and nursing care for treatment of critically ill patients. This isn't a typical patient, obviously, that comes into us on a routine basis, but it is somebody that we would be involved in helping to resuscitate and stabilise prior to going off to a neurosurgical centre for specialist care. Obviously, within our department, we use very specialist equipment to closely monitor our patients, and obviously we look at heart rate, blood pressure, respiratory rate, and all of our therapy is titrated according to the patient's need. We also use a lot of drugs intravenously, and all of our work is based on the results of that particular patient, so we know that we're giving the right drug at the right time and our therapy is accurate. Obviously, our aim is to improve the patient's condition and to continue to maintain their normal body function. Our staff are very special people. They're highly trained in caring for the most severely ill patients. The nursing staff have critical care qualifications, and we have a high patient-staff ratio. So typically in the intensive care unit, it is 1 nurse to 1 patient, and in the high dependency unit, it is 1 nurse to 2 patients. Our service is led by intensive care consultants who are there 24/7 or 24/7. Our units are across the 2 sites. On the St Helier site, we have 6 intensive care beds and 5 high dependency beds, which is a step down from intensive care. And on the Epsom site, we have 3 intensive care beds and 4 high dependency beds. All of those beds have the ability to flex up and flex down according to need. So if we need more intensive care beds, we can provide that. A typical day on the St Helier site, we would have 11 patients present on a unit. We obviously provide 24-hour care. We have 21 trained nurses to look after those 11 patients over that 24-hour period. As I said before, we have ITU consultants, which are covering 24/7, and an average of 3 junior doctors present on the unit all the time. We have 4 visiting physiotherapists to help maintain the patient, and other visiting members of the multidisciplinary team, which would involve people like speech therapists, pharmacy, microbiology, which all help us involve in the care of that patient. Patient privacy and dignity and respect is maintained at all times, and that is very important to us. We believe in treating our patients as if they're a member of our own family. We do continuous assessment and observation of patient systems, including the respiratory system, their heart, cardiovascular system, and we use, as I said before, medication to constantly titrate according to what those patients' results are and what their needs are. And we also help maintain patients' activities of daily living. So there is a minimum patient being turned 2 hourly. We do eye care, mouth care for them, and maintain their bodily functions, and obviously give them nutrition as well. These patients are totally dependent on us. So in the last year, on the St Helier site, we treated 650 patients. They were aged between 16 and 96. We have no discrimination on age. The average length of stay was 5 days, although obviously some stay a lot longer. We have emergency access from all departments and all areas. And of those 650, 131 were planned admissions. So these were patients that were coming to us post-operatively after major surgery. We provided full life support for 257 of those patients, so that's the ventilation, the respiratory support, and 121 of those patients also needed renal support, so they were on an artificial kidney, a hemofiltration machine. We also worked very closely with emergency bed service, and we supported other trusts in our area with 73 admissions that needed to come to us. Our results are very positive, they're very good. The national mortality rate, the national death rate for patients in intensive care is unfortunately 21 to 22%. Our mortality in this trust is 17.7. The overall hospital mortality nationally for patients is 30%, and in this trust our mortality is 22%. And as Matthew said earlier, he was talking about the hospital standardised mortality rate. We also have a marker of our performance within intensive care, and our standard mortality rate is 0.7, which is below national average of 1. So a typical day is a very busy one. We have constant checks, constant handovers. It does look like, I know, that there's a high proportion of ward rounds, but actually it is very, very necessary. Our ITU consultants are brilliant. They're there all the time. We obviously constantly monitor these patients. We have to see their condition changes so rapidly. So there has to be a very strict management plan, and we have to know what we're doing and where we're going to go with them. Our family is very important to us as well. Obviously our patients do not really have very much recollection of being with us. So we have an open visiting policy for our families, but we also do believe that the patient needs rest period as well. And it's also important for our patients that we try to mimic day and night, because obviously things are very different in intensive care with the lights being on constantly. So we do try to mimic day and night. There is continuous family and support and information, and the consultant and senior nursing staff will obviously always update the families on the progress of their loved one. After intensive care can be quite a traumatic time for patients and families. They're used to high input, high levels of staffing, and we feel it's very important for us to follow up our patients within 24 hours of them leaving us. And obviously we will continue to follow them up if we need to. We also give a lot of advice and support to the ward areas on management of patients that they're concerned about, and that is a 24-hour service. Our vision for the future is early identification of patients that require critical care. It's important that these patients come to us in a timely, quick manner. We've also done a lot of work with patients coming to the high dependency unit following major surgery, following nephrotomy, and that has shown very good outcomes and a reduced length of stay for the patient, which is excellent for them. So we'd like to develop that work further and look at other areas, such as orthopaedic patients that maybe could benefit from that service. And also support for families following a bereavement. That's very important. And I think sometimes, because of the nature and the complexity of things that have happened, it's very difficult for them to understand or get to grips with what has actually happened, which sometimes can be very quick or can be over a period. So we'd like to develop our service to bereaved families. We use a lot of high technology equipment, and this is a piece of kit that we were very fortunate to receive recently. It's an oscillator, ventilator, which will help us enormously and help our patients enormously, particularly in the winter, and it's specifically used for patients who have flu-type symptoms. And I'd like to thank the League of Friends, who very graciously donated the money for this equipment for us. This is some of the team. Happy team. Dr. Stockwell is there. He's one of our IT consultants. And also the League of Friends actually purchased some of these mattresses for us as well, which obviously would be great for patients' comfort and benefit. Thank you.